Thank you. Thank you again to the conference organizers for this kind invitation. And it's been a really educational forum that I think you should be congratulated for putting together so many nice, diverse topics, all of which have been very interesting for me to learn from, and hopefully we can review chronic pancreatitis and its complications, and maybe I can teach you something as well about this problem. With fibrosis in the pancreas, the stellate cell seems to be the key piece of pathology that can generate pancreatic fibrosis. And when it's stimulated, whether it's stimulated by oxidative stress such as alcohol, tobacco smoke, then these collagen synthesizing cells will deposit scarring. And it's a combination of this as well as the thicker milieu in the pancreas that can lead to the complications related to chronic pancreatitis. And I think the important aspect of this and the way we manage this very difficult patient population is based on symptoms. If patients have no symptoms with pancreatic stones, et cetera, then we don't really recommend any intervention in those patients. But most of the patients that seek attention, medical attention, have debilitating, life-altering abdominal pain. And I think that's what we have to keep in mind, is what's causing the pain is compromising their quality of life. They lose work, they get disability in the US. Sometimes they get permanent disability, and it becomes a burden on society, a burden on their own life. And then other complications can include exocrine pancreatic insufficiency. You need to lose about 90% of your functioning pancreas before you develop EPI. And this can lead to nutritional deficiencies, weight loss. Biliary stricture, of course, can occur, and endocrine insufficiency, insulin-requiring diabetes, and then pancreatic cancer. The etiologies are listed here. This is not a complete list, but genetic factors need to be considered. Yesterday there was a good session on hyperlipidemia, autoimmune disorders, and even repeated bouts of recurrent acute pancreatitis may lead to chronic pancreatitis as well. I found this study to be a little interesting because it looked at what are the factors, risk factors for patients, and how they associate with different complications, and more inflammatory complications with chronic pancreatitis is more alcohol related. So that's this first cluster. So pseudocysts, ascites, pleural effusion, so forth. These are more inflammatory and more alcohol related. The smoking related, fibrotic related complications tend to be the ones that may lead to stenoses, duodenal, biliary, pancreatic. And so I found this interesting because when patients continue to smoke, especially despite endotherapy, oftentimes their rates of recurrence of pancreatic stricture seem to be high, and they don't do as well in some clinical studies. So my approach to symptomatic chronic pancreatitis is determine the etiology, consider genetic testing if appropriate, depending on age and family history. Although even in the absence of family history, we'll consider genetic testing in appropriate patients. Strongly encouraging the cessation of alcohol prior to beginning endotherapy. And then primarily this is because of just other complications that occur related to alcohol use or alcohol abuse. So we generally don't begin pancreatic stenting or treatment of pancreatic duct stones unless their alcohol is they're not drinking any longer. Unless they're hospitalized, they have a symptomatic pseudocyst, walled-off necrosis, or if they're getting frequent hospitalizations for obstructing pancreatic duct stones, then we're sort of left to treat it even in the presence of alcohol, just to try to reduce the burden on for the patient and for the healthcare system if they keep coming in with symptoms that we think can be related to an obstructing stone. And the most important thing we can do as physicians, I know we're endoscopists, but we're physicians first, is to encourage them to stop smoking. And I know it sounds funny, well, you send it back to the internist, the primary care physician. It's really amazing to me that when you become their pancreas doctor, suddenly they find it more motivating to stop smoking. And when you tell them that the risk is higher if they smoke and have chronic pancreatitis to develop pancreatic cancer, they're okay with heart disease, they're okay with lung disease, but boy, you mentioned pancreatic cancer, and they're like, whoa, hold on a second. And then they take it more seriously. I don't know. So I actually spend time talking to them and their family, because if you get their family involved, they can also be a good way to show for the patient to feel guilty about their smoking too. So that's my internist moment right there. So you want to know, how motivated is the patient to minimize narcotics. Sometimes by the time they see us, they're already dependent on narcotics, and it unfortunately becomes a difficult time for us to then try to do interventions that might reduce their ability to come off of narcotics. So hopefully we catch them a little bit earlier. And narcotics are a problem in the US for sure. With pain management, it's becoming more and more recognized not to immediately just give the patient narcotic for pain, and they're being more thoughtful now, trying other alternatives. So if the pancreas duct is dilated, then my practice is to do endoscopic ultrasound, even if imaging is negative, do endoscopic ultrasound to exclude neoplasia, and then ERCP if there's any stones to remove, and considering a trial of stenting. If there is no dilated pancreatic duct and there's pain that's related to eating, food related, then I will consider a 2-week trial of pancreatic enzymes, non-encapsulated enzymes. Those are difficult to find, so sometimes I'll have them split the capsules, sprinkle the granules in yogurt or applesauce, and then don't have them chew the granules, but just a third of the mixture at the beginning of the meal, third of the middle, third at the end, in addition to acid reduction with PPI therapy. But I'm very careful to just try it for 1 to 2 weeks, because you see so many patients, these are expensive medications. And so I try to get patients off of them. They think that the enzymes are actually helping their pancreas. It's really not doing that, as you know. But the patients think that. So I try to get them off. If it's not working, then, and there's very poor data on whether it helps anyway, but it is something that I consider trying. And then I often will do anti-inflammatory, acetaminophen, consider antioxidants. There's some data on that from India related to in tropical pancreatitis of antioxidant use, or I just recommend a higher diet related to antioxidants, and then consider neuromodulators and a celiac plexus block potentially for managing pain. So the abdominal pain causes can be strictures, stones, pseudocysts, they're neuropathic, and of course pancreatic cancer. And this old slide from the 1900s still is a very helpful one, because it shows sort of the complex etiologies of pain related to chronic pancreatitis, increased pressure, not just in the duct, but in the parenchyma, inflammatory changes from alcohol and so forth. And the neural inflammation ones are probably the most challenging patients. And sometimes trying to figure out if the pain is pancreatic, is it a disorder of the brain-gut axis? All of these things are complex. A 78-year-old female with a history of chronic pancreatitis presented with increasing pain and weight loss. And on the imaging, you can see that the pancreatic duct is markedly dilated. When it's this dilated, you worry, especially with the weight loss. What could this be? So endoscopic ultrasound is performed, and dilated duct. But the worrisome feature is not so much a hypoechoic mass, in my opinion, but you see how thick the wall is of the duct. That's very worrisome. This is actually quite thick. Maybe there is a mass there. So we sampled it. Oops. And it did show, it was suspicious. Surgery confirmed cancer, but it was suspicious by cytology. So exclude pancreatic cancer in patients with chronic pancreatitis. Bile duct stricture may occur up to a quarter of patients with chronic pancreatitis. And we manage these with biliary stenting. We do fully covered metal stents early on to help resolve the stricture, really encouraging the reduction in tobacco smoke or cessation of tobacco as well. Pancreatic stenting, we do this for ductal hypertension. How do we know there's ductal hypertension, dilated pancreatic duct? This is a patient with idiopathic, recurrent acute, subsequently chronic pancreatitis, maybe modest alcohol tobacco. You see a stricture well defined here in the head, balloon dilation, only a 7 French stent. Normally I'll go up eventually to 10 French, but in this case, the stricture resolved with just 7 French stent. And I think that we generally need to get up to 8.5, 10 French, sometimes multiple plastic stents. Some of this older data, we're looking at patients who would just get a single stent. And this is one of my criticisms of the RCTs that were done in Europe comparing surgery and Pusteaux. I didn't include those slides in my talk today, but these are a very select group of patients. They do not maximize endotherapy. And I think the key for us, if we're considering stenting, if patients aren't interested in surgery, is to be sure we optimize and really try and resolve the stricture by more than 85, 90% resolution before having the patient stent free. But several studies, follow-up periods are variable. In looking at this, the right-hand column shows a low to moderate number of patients that eventually require surgery. So some data that looked at over 1,000 patients over 5 years found significant improvement in pain, but this is very subjective and difficult to control for narcotic use as well. A quarter of patients require surgery eventually, and I think that also this is older data where there wasn't a maximal therapy, endotherapy, I think, with multiple plastic stents, for example. And then they looked at 15-year follow-up in about 50 patients, and they did find that the rate of exocrine dysfunction was 10 years slower than previously published natural history data on chronic pancreatitis. I find this interesting. It's very limited. It's the longest data that we have, longest follow-up data for chronic pancreatitis. But sometimes I will use this information to tell patients that, look, if you stop smoking, if we commit to this, there's a chance that you might get some improvement in function. We all know that once fibrosis is there, that the pancreas does not regenerate. But there may be some preservation of pancreas. EPI may be preserved to some degree or improved. And then absence of smoking, there's a better result in this study. And then this is a patient who I had placed a plastic stent. They were enrolled in a clinical trial of a fully covered metal stent, the Wallflex stent. And this was an 8 millimeter. Maybe I should have used a 6 millimeter, I don't know. But this was an 8 millimeter fully covered stent placed. I think it placed in good position. And this is follow-up at 4 months. Complete cutoff of the duct upstream of where the stent was placed. Sure, the stricture is resolved, but she's got bigger problems now. She did fine for 15 months and then had recurrent pain. And this was the pancreatogram at 15 months. And you can see it looked like divisum. And I couldn't really find the minor papilla. I can't remember what I did with the minor papilla. But that would be one option, is to go through the minor papilla. She ended up going for Pusteaux, lateral PJ. If you remember anything about my talk, please do not place metal stents in the pancreatic duct. There is no indication, in my opinion, to consider metal stent in the pancreatic duct. And so this is an example, though, of data that we've published along with my mentor, Doug Howell. And we looked at going through the minor papilla. These are not patients with pancreas divisum, but we go through the minor papilla if there's ventral duct obstruction. So keep this in mind. If you can't get into the ventral duct through the major papilla, look for the minor papilla, and you'll be pleased at how often you find it without even secretin, and can access and do therapy that way. This is a patient with chronic pancreatitis, recurring bouts of acute pancreatitis, post-Whipple, and you see an anastomotic stricture. You can barely see the opening. It's just literally a pinhole. And then subsequently, I showed a video yesterday of stricturoplasty. We're using laser. But really, the original stuff on stricturoplasty was treating hepatocojejunal and pancreaticojejunal anastomotic strictures. So I use needle knife here. Usually I try to get at least 2 quadrants, if not 3, but I combine needle knife cautery with balloon dilation for subsequent treatment, and then I do follow these with a stent, especially in the pancreatic duct. In the bile duct, I don't think a stent is always necessary if you're treating a hepatocojejunal anastomotic stricture. This is a 58-year-old post-Whipple for cancer, recurring pancreatitis, abdominal pain continues, and this is the MRCP showing a dilated pancreatic duct, unable to do ERCP. I attempted it, but unable to do it as a failed ERCP. So we proceed with EUS-guided, or attempt at EUS-guided drainage. These are the most difficult pancreas biliary procedures, I think, is EUS-guided pancreastrostomy. I think that, I mean, this is a good target. Of course, I'll show you a successful case. I won't show you my failed cases, because the pancreatic duct is just very difficult to get through. You get the stomach wall, it's thick. You have all the fibrosis around the pancreatic duct as well. So we show you some of these videos, but the published data on this, 70% success rate. It's literally, other than trying ERCP and Roux-en-Y gastric bypass, this is about as low a success rate as I don't like to see it, but that's really the reality. But we use a 19-gauge needle, pancreatogram, get a wire in. We don't have a good cystotome, which is just amazing to me still. We don't have the 6 French cystotome. So we use a needle knife, or even I'm going to try this really thin 4-millimeter balloon to try and avoid cautery. But essentially, I use needle knife here to create the pancreastrostomy, balloon dilation, and then subsequent plastic stent insertion. I usually will stent for a year. So in about 2 months, I would change it out, and then 3 months later, every 3 months, change out for 1 year, with the idea that that tract matures after about a year, stent-free. I've re-intervened on panc bulbostomy that was done in 2008, so about 12 years later. That's the oldest panc bulbostomy case that I've had, and the tract remained mature. So there is a role for intermittent stenting if necessary in those patients. Pancreatic duct stones, I'll just mention here, ESWL versus pancreatoscopy. There's some advantages of pancreatoscopy, targeting multiple calcifications, trying to figure out which of the stones are intraductal or parenchymal. I think it's hard to sometimes distinguish that when you use ESWL because you're relying on fluoroscopy. Radiolucent stones are difficult to target with ESWL. There's also a high rate of pancreatic duct strictures, and so we have to treat those. Otherwise, stones will be difficult to clear. Also, stones may be recurrent if you don't treat the pancreatic strictures. There's a meta-analysis looking at both EHL and laser lithotripsy, intraductal, only about 400 patients, with a modest technical and clinical success, and adverse events that include pancreatitis. This is just a video. I think I'll finish with this. This is pancreatic sphincterotomy. I tend to do pancreatic sphincterotomy to run parallel to where you anticipate the bile duct sphincterotomy to be present. So sometimes we'll do biliary sphincterotomy first, followed by pancreatic sphincterotomy. But then in any event, you just need enough room to pass the pancreatoscope, the spyglass system, which is 10 French system, as you know. And even if a stone is obstructing in the pancreatic head, you can pass, as long as you have about 1 centimeter to work with, you can get to the stone. You don't need to get the wire beyond the stone. In this case, I was able to, but you don't need to get the wire beyond the stone. You just have to get to the stone. Sometimes the stone is completely obstructing the duct. And in this case, we're utilizing EHL. This stone broke up quite nicely. And then I will follow this with a stent. Multiple studies that have been done comparing S-wall versus pancreatoscopy, 2 prospective, total of only 90 patients, and ductal clearance fairly similar between the 2 groups, and adverse events are noted here. We're involved with an RCT looking at this very question of ESWL versus pancreatoscopy. Enrollment is open. It's been very slow. The pandemic slowed us down a bit, but we're still actively doing that. So maybe if I have time, maybe for one last video here. This is, I showed a video yesterday. I'm not going to show you this video actually. This is the earliest, our first series of using laser stricturoplasty and ablation in the pancreatic duct in refractory cases from a few years ago. And I'll just finish with this case of chronic pancreatitis. This is different than the case I showed you yesterday. It looks similar. I even had to double check, but it is a different case. This is a pancreatic stone in the mid-body. You can see a cutoff of the duct. Only can get to the level of the stone, nothing above it. We just put a stent to the area of stone, and the patient developed a pseudocyst and worsening pain. So this is an adverse event related to the procedure. And subsequently, and the pseudocyst was a little too small for drainage by transgastric approach. So we use laser stricturoplasty here to open up the pancreatic duct by pancreatoscopy, and then subsequently can break up the stone. And now you can see the tail, the body tail that is visualized and stenting, and the patient did great. This is a case I did just a few months ago. So that's the pre-pancreatoscopy image here. And then that's the post, how it looks. You can see preservation of the tail. And the pseudocyst resolved on follow-up CT scan. So in summary, pain relief is the primary goal. Exclude neoplasia. If the duct is obstructed, then use plastic stents. And pancreatic stones can be treated, intraductal or ESWL, depending on what your resources are. And then stricturoplasty is still preliminary. Thank you.